press, but then also are very proud to have Dieter Handloser from SCHÜV, Stefan Breitenstein from KSW, as well as Lukas Ganner from KSW in Hirslanden, give an update on their clinical experiences with Dexter. My name is Michael Friedrich. I've been with the company for 10 years, been with the project since the very, very early days. And I would like to just start by I think that's how it works, by just giving you a quick update on who we are and what we do and why we do it. Some of you have been following in our journey for a few years already. Others might be new to Distalmotion and Dexter. Hence, a quick introduction on who we are. We are a company based in Lausanne, in the western part of Switzerland. We are initially a spin-off from the EPFL, the Institute of Technology in Lausanne, have started by now 12 years ago, so a long time ago. Are 165 team members. We are growing about 40 team members every year, so in a really strong expansion phase. And by now we are very proud that we have been able to treat over 1,000 patients with Dexter since the real clinical start a bit more than 1.5 years ago. We have a very good safety profile in what we do. We have had no severe device-related adverse events, so Dexter really has proven safety, but it also has proven versatility across 35 different procedure types in urology, gynecology, and general surgery. I'll talk about that a bit more in a second. Since we are at the Swiss College of Surgeons conference, I'd like to highlight that Dexter is a Swiss-made platform as well. The robot is made in Frauenfeld, the instrument's close to Fribourg in the western part. What problem do we solve with Dexter? We solve essentially we reduce the barrier to get more patients access to minimally invasive surgery. In today's traditional laparoscopic approach, as you all know very well, doing laparoscopic suturing and laparoscopic dissection is not only very difficult to learn and to perform, but it's also very exhausting as a surgeon given the ergonomics of the typical working position when doing laparoscopy. That is a real issue in getting more patients access to high-quality minimally invasive care. The second one is that traditional robotic approaches are rather complex, they're rather expensive, and they really create a barrier between the surgeon and the patient, where as a surgeon you're forced to do everything with the robot, even if at times during the procedure it would be better to be able to access the patient. And that is what we are solving with Dexter, our surgical robot. And when I looked into the preparation of this presentation, I remembered that more or less exactly 7 years ago, we were here in that very same building with a super early prototype, a predecessor of Dexter, that you might see on the right side, those black mechanical arms that we got surgeon feedback from. Dieter hosted us at the time. We also had articulated handheld instruments that we tried really to learn and figure out what a good robotic approach would be for you, the physicians, but also then for the hospitals, so that the hospitals could adopt and afford these platforms. Now, 7 years later, we are super proud that we are on a very mature platform. We again have treated so many patients that today, for us as the ones that have built the company, we are very proud that now we can walk through cities in Europe, many cities also in Switzerland, and we can bump into people that have been treated with Dexter or with the help of Dexter, that we will never know who they are, we will never talk to them, but just that feeling of meeting people or seeing people in the street that could potentially have benefited from what we do makes us really proud. Today we have starting to have good adoption in Switzerland specifically as well. We with the speakers that I mentioned before from SCHÜV, KSW and Hirslanden, we showcase clinical experiences with teams that have had Dexter for some while already, but now we also have KSB Baden, we also have Inselspital as clients, so we really start to show that Dexter becomes a clinical reality in day-to-day clinical use. Dexter consists, and you will be, by the way, are most invited to have a look at Dexter down at our booth. We have it at the booth, you can give it a try. Consists of a surgeon console on the left side where the surgeon's hand and wrist movements are captured. Two patient cards that you see in the middle. that each holds one instrument replicating the surgeon's hand movement from the console into the patient, and the third arm on the right, the smaller arm, which can hold any endoscope. So today we have surgeons, hospitals using the latest 3D 4K from Storz. We have others that work with the latest Olympus systems, with Esculap. It's really up to the physicians and the hospitals to choose what imaging systems they prefer to use. Given that our focus with Dexter is on simplifying suturing and dissection, our instrument lineup corresponds to these tasks. So we have the classical instruments with a needle holder, fully wristed and fully articulated needle holder. We have a bipolar Johann, a bipolar Maryland. We have a monopolar scissor and a monopolar hook. Really the basics for good suturing and dissection tasks. What is really unique with Dexter, for those of you that have robotic experience, is that we raise the bar when it comes to dexterity compared to every other solution in the market. Our instruments are not only wristed, like you would expect from a robotic platform, but we also introduce clutching function on the wrist. So with other platforms, you might remember or might know that you can clutch the translational movement, so the left, right, the up, down, and the in, out. You can push the clutching pedal or push the clutching button on your hand and reposition your hand outside. What we do with Dexter on top of it is we can clutch the roll function as well as the pitch and yaw, so the full wrist function. So that means you can be in a procedure. Imagine you need to do a complex backhand suture. It allows you to articulate your instrument blades into a position that is ideal for placing that suture, but clutch your hand again into an ergonomic straight position. And then when you rotate your hand, your instrument, your wristed instrument actually follows the movement that you want the needle to do in order to place that suture. And that really, and again, please come and try it out yourselves, that really improves substantially the ergonomics for the surgeon when you do these complex wrist movements. So that's, I think, pretty amazing that 25 years after the invention of robotics, by focusing on robotics and by rethinking robotics within the core functions of robotics, we can actually go beyond of what the standard is today by introducing this wrist clutching function. With this platform, we are over the past 18 months, our focus has been to demonstrate not only that Dexter is a very safe system, but also that it is a very versatile system, meaning we have demonstrated that Dexter can be used, and those slides are available if you would like them afterwards. We've demonstrated that Dexter really works not only in very high complex procedures. I believe Stefan might be talking about the Whipple that he has done two months ago. We have done about more than 100 prostatectomies, 80 or 90 partial nephrectomies, colorectal procedures that Dieter will talk about. So really highly complex, highly sophisticated procedures, but we also have shown that it works equally well for procedures that today do not yet have access to robotics, so the high volume procedures, the hernias, the choles, these types of procedures that today do not yet get access to the benefits of robotics. So really, really versatile platform. Why Dexter? And again, I have 2 or 3 slides left. I don't mean to do too much of a company presentation here, but then give the surgeons the opportunity to present. I think 3 reasons for why Dexter. First, really, it's the excellence that Dexter gives you into the clinical workflow. With the dexterity that we spoke about, with the outstanding ergonomics, but also with the fact that Dexter is an open platform. With Dexter, because as a surgeon, as you might see on the picture on the right, you can, if you want, stay scrubbed in. You can stay within the sterile field when operating with Dexter. You can easily approach the patient. You can easily, within 10-15 seconds, you can switch from sitting at the console to having your preferred stapler manually inside the trocars that you previously used your robotic instruments for, because Dexter has been designed in a way that gives the surgeon easy and rapid access to the patient. You can really not only use your best imaging, but you can also use your best specialized tools, whether that is your preferred stapler, your preferred advanced energy instrument. And that really allows you, within each of the tools that you use in your procedure, to use best in class for what you need for your procedures. A second thing that is really unique about Dexter, and you will experience it when you work with it, is the simplicity. We always had the ambition to make Dexter as simple as a drill, to really lower the learning curve, shorten the learning curve, and I think we have succeeded in that. It really integrates into the workflows. It makes also the reprocessing easier because we have single-use instruments, so no complexity on cleaning your instruments. You always have clean and well-functioning scissors. You don't have to worry about these workflows. And then the last but not least, it's really the accessibility. It is clinical, which means the clinical versatility, but also the economic flexibility of getting Dexter into healthcare systems, into reimbursement realities that so far have prevented the adoption of robotic surgery. Again, why Distalmotion? I think what really sets us apart is that we are, in every single case, in every single procedure, we have someone from our team on your side, working with you, supporting you on the case. That not only gives you the comfort that there's always someone there who works with you through these procedures, but it's also a great opportunity and a very important opportunity for us to learn from you on how to do these procedures, how to do the port placements, how to do the setups, but also what to still improve on the product, because we have the ability as a small company that is close by to really iterate on these products very quickly. Every 6 months or so we deploy an improvement of the system. And again, you might have remembered the picture I've shown you from Dexter 7 years ago. In only 7 years, we have come a very, very long way, and we really pride ourselves in being close partners with you here in really moving the barriers in robotic surgery. We also pride ourselves in being really here with you, for you all the time, very transparent of what works, what doesn't work, because we really want to learn from you on how you see robotic surgery and how you see the clinical realities and what tools really make best sense for you instead of imposing something up on you. So with this, again, the invitation, come to our booth if you like to see Dexter, come to Lausanne if you like to try it, and come to our clinical partner sites to see Dexter in real life use so you can get your own opinion about Dexter. Thank you very much. I would like, as next presenter, to introduce Dieter Handloser, our long 8-year journey.
We'll have now 3 clinical talks. Obviously, I will talk about colorectal surgeon because this is what I do in life. And I would like to talk to you about, how Dexter combines the best of 2 worlds. These are my disclosures. We'll talk about surgery, but the 4 most non-intellectual reasons to use a robotic platform you can see here. And one very important one that we just have neglected over all the past years is the sitting position of the surgeons. When we teach or when we operate, we are not in a semi-rotation position doing the surgery because we are sitting and being very comfortable. You have seen the Dexter already. Just to remind you, it's an open platform. You do not need a dedicated robotic operation room. You can move it around to the urology room, to the upper GI room, to the lower GI room, where all the other materials you already have in those rooms ready, the stapling devices, the electrocautery, and everything is already there, and you just hook it up. So that's also a little advantage that I think is very, very important nowadays. So the best of 2 worlds, what does that mean? Robotics gives you precision, reduces complex tasks to simple actions, and laparoscopy, you use it when you do big movements. The robots are very good in narrow space and little movements, but they're probably not as good if you have to do big movements. And I will tell you that. And the surgeon being sterile at the console, he can very easily switch from one side to the other side. So he can actually jump, and it's not that you use the robotic platform for 2 hours, 3 hours, but you can switch back and forward where needed. So I'm going to show you that on two colon procedures, which would be right colectomy and rectopexy. Why right colectomy? Because right colectomy for cancer has now clearly been shown you need to do a perfect specimen resection, CME, and a central vascular ligation. And this can be very complex. You need to know anatomy in advance. You need to have, for example, the right colic artery is present in 60%. The left colic vein has different origins. The right colic vein has different origins. The ileocolic artery is most often posterior to the vein. So those are things you need to know to do a perfect operation. I'm not going to go into the debate, should we do for all cancers a D3 lymphadenectomy, but at D2, taking all the lymph nodes alongside the superior mesenteric vein is today mandatory. And here comes the danger with the variations of the so-called Henle trunk. As surgeons, we need to plan that because we need to do a perfect operation. So I'm going to show you, this is obviously a laparoscopic procedure. This is a right colectomy. We are looking up, we're lifting up the ileocolic vessels. You see the superior mesenteric vein coming there. You have a lymph node there that you need to take out. You do the dissection, you do the cautery, you dissect alongside the the superior mesenteric vein, and then that happens. You know, that happens, and then obviously you try to correct, and I'm going to show you that now in detail what we had to do in this case. So this is a complex task of an actually not so complex procedure, which is the right colectomy for cancer. But this is a very complex part of it and can cause harm. And here the robot can help. In this patient at the end, we were able to do the operation and had all those lymph nodes alongside the middle colic artery and the vein taken out. So what do we do now with the Dexter, with the robot? We use this smiley position of the trocars, identical to what we do in laparoscopy. We do not need to set up the trocars in a different way, which for other platforms, robotic platforms, we need to do. And then when we go into the robotic part, then or in the laparoscopic part, the trocars are not in the right position. So here they are in the smiley position, as I tell you. So what we do first is we dissect, we lift up the ileocolic artery, and we do a kind of medial approach first, go a vessel approach first. There are various techniques that have their advantages and disadvantages. And here we do, and you can nicely see the advantage of the angulated instruments. The dissection is very clear. You have a bipolar device using just right now, and you have a monopolar device. But where the clear advantage is here is this lymphovascular dissection central. You see here we are dissecting with the robot using cautery and bipolar. This is the superior mesenteric vein you can see, and in this case the artery goes above. The ileocolic artery goes above the ileocolic vein, and you can do a perfect dissection. You can take all the lymph nodes, and this is extremely important. The data has been shown, increases survival and everything like that. This is not the purpose of today's talk. So here we identify the artery, which goes above the ileocolic vein, so we dissect it free, and this is where you need the precision, where you need the dexterity of a robotic platform by doing this operation. Now we've dissected free the artery, as you can see here. Obviously this is a little bit speed up, it's 2 times the speed, it's not like that I'm that fast. And then we put in the clips. You use whatever clips you're used to. You know, what you have in your hospital already ready. You don't have to have the robotic clips or the robotic staplers. You use whatever is there, and you clip your vessels and you cut them. Here you see us cutting the ileocolic artery, done now. And then we go on and take care of the ileocolic vein. You need to free it up. You can do precise bipolar dissection. As you can see here, you have the scissor and you can cut everything. And you have a pretty stable platform. Obviously here everything is a little bit moving because the patient is alive. So that's the pulsation of because we're close to the vessels. So again, here we clip the ileocolic vein, again with 2 clips and cut in between. as you can see here now. And then we go on, and that's important. Many people then stop and then don't follow the vessels, but here you need to follow up the vessels until you come to the middle colic artery, and from there on go up to the colon for a right colectomy. You see the pancreas coming up, and now we go further up, and in this case there was a right colic vein coming out directly of the superior mesenteric vein. We knew before because we need to study the CT scans. And here you can see us going up, and you see the vessel coming up, which we freed up here, again, put some clips, and went on. So here you have the precision that is needed to do an oncological, correct, and for the patient needed operation. As you can see here, again, dissecting, you can see the nice movements of the wrist, which you cannot do with standard laparoscopic instruments. Free it up, put in some clips, as you can see here, and that's the assistant. You know, none of the procedures today are fully robotically without having an assistant, a human trocar helping us. Everybody has that. So here also you need one to bring in the clips, and you dissect. And here then we went up, going towards the ileocolic vein. Here's another patient just showing you that this is the dissection of the right branch of the middle colic artery. You see in the lower part, you see the pulsation. We are freeing up here the artery, looking for the vein. Again, here we go alongside the middle colic artery. Here's the colon, so you can free that up, everything, do a precise dissection, and you will see again here we're at the colon. We free up the vessels. You see the artery pulsating in the lower part. The vein will come up, and then we just place the clips, cut it, and go on. So there is precision. And then we switch. The next part in the right colectomy is mobilizing, medializing the colon from lateral to medial. Obviously, we do that in the laparoscopic mode, and we switch. And this is just showing you real time the switch. It doesn't take much time. The surgeon goes from the console to the robot, takes out the instrument. It's not the surgeon that has to do that all the time. Also, the assistant or the scrub nurse can do that. But just to show you how fast actually it is, you take it out, arms fold back and give you the space you need to be operate in a laparoscopic manner. You can use the stable camera robotic arm or not, it's up to you. You can also use it. Sometimes it's good to have the stability, sometimes it's not, and you just unhook it. So very straightforward, and obviously the change is in 20 seconds. And then you do the laparoscopic part. As you can see here, this is Dr. Grass operating. He's doing the laparoscopic part where you don't need the precision, the precise movements, and where you are much faster. And here again, the medial to lateral mobilization of the colon can be done laparoscopically, as you can see here. It can also be done with the robot. It's not that it's not possible, but there is no advantage. It's not as fast. You don't need the precision, but just to show you, we did it also robotically. And then you go back again where the robot is the best. Here, intercorporal anastomosis. We staple off with standard staplers. We have the colon. This is a fluorescence, as you can see, to check for vascularization. This is the stapling off of the transverse colon. The terminal ileum is stapled off. Then we do a side-to-side isoperistaltic anastomosis, intracorporal. I think this is standard now for right colectomies. You do that, we staple it, and then you just bring in the robot again and you do the suturing. Much easier suturing, you know. Suturing with a robot is so precise and is so easy because you have the full movements of the wrist. Here we're closing the defect with a running suture of a V-lock, and then we just put some other stitches above it just to obviously don't have leaks. Here you can see a little close-up, a nice, placing another additional suture, and you can see that it is very easy and can be very easily done. The suturing, it's easy, it's much easier than in laparoscopic surgery. I did Tuesday rectopexy. Going to show you that. This was a woman that needed for an obstructed defecation a rectopexy. The uterus is on the top. You see the deep pelvis. We open the septum, the rectovaginal space. You dissect it by using monopolar and bipolar coagulation. Here you see the rectum showing up. So easy dissection, freeing up, going down to the pelvic floor. We dissect the promontory here to fix the mesh. So here you see the promontory. You can have these little movements. You have bipolar. Here a little vessel, coagulate, separate, free up the bone so you can afterwards fix the mesh for a rectopexy. As you can see here, this is the mesh. We use this type of mesh. We place a suture at the lowest part, and this is very important because the mesh needs to be very good fixed in the lower part. Here you see the upper part is the vagina, and you're just 1 centimeter from the anus, placing the suture again in a very easy, straightforward manner, and then just fixing the mesh to the rectum and to the promontory. And the end, you know, this is a suturing exercise operation. There's a lot of suturing. This is an operation we do fully robotically, so there's no laparoscopic part in it. We do fully robotically. You see us here putting the sutures, fixing the mesh. Usually we use about 5 to 6 sutures. The distal sutures have already been done, and here we're just fixing to the proximal sutures, as you can see here. So very easy. I usually try to do 2 knots with 1 sutures of 15 centimeters. You can do 2 knots. It's also doing a little economy. Here you can see bringing in the second one, the assistant helping you, and again suturing in an easy way, fixing the mesh, obviously speed up. And then here is the bigger needle going through the promontory to fixing the mesh to the promontory. Here again, it was a young lady, so quite tough bone. So you need a little bit of force, you can see here, but you can see exactly, you don't need the haptic feedback. You can see what you need to do. You push the needle, you push it through, take it out, and then you fix the mesh. We usually fix it with 2 sutures to the promontory. It's a little bit less painful in my experience than using tackers. So we also do the suturing here with the robot, obviously is very easy. Here the 2 knots, the second knot, just putting it in place, as you can see here. And at the end, like in all operations, the peritoneum is closed above the mesh just to prevent adhesions. You will see that in a while. Here is just the suturing. Sorry, the video was just made 2 days ago. And here you see the suturing, actually the closing of the peritoneum above the mesh with a running suture, a V-lock type of suture, just to closing it, as you can see here. And at the end, we did the operation in a robotic way. Here it's a little mistake, you know, you correct, you go in, it's straightforward, you push, suturing is really made everything quite easy and straightforward, and that's where you have the precision of the robot, and this is a fully robotic procedure we're doing. Here is the end. So we've published our first 12 cases last year. As you can show here, we did 2 rectopexies in those 12 cases. The rest were right colectomies. There was 1 transverse colons. Some of them were for cancers, some of them were for polyps. This is just really our first 12 cases done with the robotic platform. Obviously now we have much more. As we converted once because the patient was just too fat, or twice actually, the patient were very fat and we were not able to do the good exposure. We also didn't have the trocars at the right position in those times. My second patient I've done needed a little bit more of trocars because I did not place them at the right position. Also, we did the mistakes for you. You don't have to do them again. We'll tell you how to put the trocars. We didn't have any robotic-related complication. As Mike already told you, we had the typical complications of a right colectomy, nothing to do with having used the robotic platform. So this is Dexter. This is how we used to introduce it in colorectal surgery. And I thank you very much for your attention.
So, thank you very much for the warm introduction. My name is Lukas Gantner and I'm a surgeon at Cantonal Hospital of Winterthur. As of this moment, I'm doing a rotation at Hirslanden Clinic Zurich in the Center of Surgery Zurich. First, to me as a person, I'm an early career surgeon. I graduated the University of Zurich in 2015. I received the bulk of my surgical education at Cantonal Hospital of Winterthur, and just in 2022, I finished my board exam for surgery. And up to December 2022, I didn't have any robotic training whatsoever. What changed in the last year is we got the Dexter robotic system, and now in less than a year I was able to do over 100 cases with the Dexter robot. So I want to give you a quick overview of my journey with the Dexter robotic system. So in December 2022, we started in Canton Hospital of Winterthur to work with the robotic system, and just before Christmas, we performed the first robotic cholecystectomy. Then we went on to go to do robotic inguinal hernia repairs. Pretty early on, we were able to do the FDA study for hopefully for FDA approval in the end of the year. And after we did the high volume cases, we also went to the more complex cases. I was involved in developing the setups for the other cases we now do with the robotic system, so sigmoidectomy, right hemicolectomy, gastric bypass, rectopexy, hiatal hernia, ventral hernia, incisional hernia, and Professor Breitenstein will talk probably a bit about even pancreas resections. So what's on the map for the future? Hopefully, or we're going to do further FDA trials. I'm looking forward to expand and optimize the already existing setups, and now that I'm at Here's London Clinic doing my rotation, and they just newly joined the Dexter family, I'm very happy to help building the Dexter program there as well. This is an overview of my first 100 cases. So basically, there were the high volume cases, so robotic inguinal hernia repairs and robotic cholecystectomy, but a few of the more complex as well. And I'm really very much look forward to expand this sector in the future. But my bulk of the experience is in cholecystectomy and inguinal hernia, and want to show you how this works. So as Professor Hanlose told you, we want to stick to the trocar positions we have in laparoscopic surgery to make the conversion, if you want or if you have to, very easy. So we basically have the same incisions. We dock the robotic system, we do the dissection of the hepatocystic triangle to achieve the critical view of safety. And when we have done that, you change from the robotic console, you're scrubbed in, the console is draped, so you stay in the sterile field. You go to the table side yourself, you apply the clips, you do not have to have an expensive robotic clip applier, you do it laparoscopically, you cut the structures, and as you can see here, I only work with the surgical tech present, not with another surgeon at the table side, and the access to the patient is just very quick and easy. This is especially comfortable in your early learning phase when you know whenever you have a problem, you just go to the table side and take control of the situation. And after you have dissected the structures, you switch back to robotic mode, you fold back the arms, you dissect the gallbladder off the liver bed, and you finish the operation. The major part of my experience, as I was involved in the inguinal hernia study, and as Canton Hospital of Winterthur is the biggest hernia center in Switzerland, I had quite a bit of exposure to inguinal hernia surgery, and I prepared a short video where I will show you an inguinal hernia repair in full, and also talk a bit about the study. So I will just let you enjoy the video.
Hi and welcome to my video for the Swiss College of Surgeons annual meeting 2024. I'd like to show you the setup and procedure of a robotic top performed with the Dexter robotic system, as well as present to you the results of the feasibility study we conducted. The small individual parts make the system very mobile so that the robot can easily be moved between ORs. This gives you a lot of flexibility as well as accessibility to almost any operation room, even ambulatory centers. The system is easy to set up. Special to the system is that the console is also draped. This gives the surgeon the possibility to stay in the sterile field, ensuring a quick and easy patient access. The design of the robotic arms enables you to operate with the trocars in the same position typically used in laparoscopic surgery. Docking can be done very quickly, with a trained team able to complete the process in approximately 2 minutes. After calibrating the height of the system to the abdominal wall, with a push of the button the arms fold down into robotic mode, followed by the insertion of the instruments. Once the installation is complete, I move over to the open console to start the robotic part of the procedure. This can either be done sitting or standing up, depending on the surgeon's preference. For robotic top, I use monopolar scissors on the right and bipolar Johann grasper on the left, Later I will switch the right instrument to a needle driver for suturing. If preferred, a bipolar Maryland dissector and a monopolar hook are available as well. All instruments are wristed, as you would have it in other robotic systems. As of this moment, all the instruments are single-use with a multi-use option in development. After the dissection is completed and the critical view of myopectoneal orifice is achieved, the mesh can be placed. Demonstrated here, you see how quickly you get access to the patient. This is great either in the case of an emergency or if you prefer to do a part of the procedure laparoscopically. This also gives you the freedom to use the specialized laparoscopic device of your choice comfortably from the table side. Here you can see me inserting and placing a 17 x 12 cm 3D mesh. I prefer to do this part of the procedure laparoscopically as I'm more efficient, and in my point of view I do not really benefit by using the robot. After the mesh is placed, I fold the arms back down into robotic mode. For suturing, I now switch the right instrument to a needle driver and go back to the robotic console. I finish the operation by closing the flaps with a barbed suture. Usually I perform the procedure without the surgical assistant, with only the surgical tech assisting me during the setup and breakdown of the robot. Whenever it is necessary to intervene from the table side, as demonstrated before, it is very easy and fast to switch to laparoscopic mode. This is especially beneficial during your learning curve. So if you are trained in laparoscopy, you can very comfortably fade from a laparoscopic to a robotic procedure as your experience grows. At the end of the operation, the brakes are released, allowing the patient cards to be rolled aside. This provides immediate and complete access to the patient within seconds, demonstrating the system's rapid response capacity in emergency situations. As you now have an overview of how the robotic system works, I want to go to the feasibility study and show you some of our data. It is a prospective multi-center trial including 50 patients. The operations were done by 3 surgeons from France, Germany and Switzerland. As this trial is the basis for FDA approval, its primary objectives are safety and performance. So we looked at adverse events rates during the 30-day follow-up, as well as conversion rates to laparoscopy or open surgery. Secondary, we also looked at short-term perioperative outcomes. This is an overview of our study population. The age was around 60 years old, the BMI was quite low with 25.7, gender was predominantly male, as inguinal hernia is predominantly a male problem. The ASA score was mostly 2 or lower. 2/3 of the operations were unilateral and 1/3 bilateral hernia repairs. Displayed here, you see the intraoperative results. We had no conversion to open surgery and only 1 conversion to laparoscopy. In the case where this occurred, the trocars were placed too low, so that the reach of the robot was limited during the lateral wide dissection. Still, the main part of the procedure was performed with the Dexter robot. The operation time skin to skin for unilateral hernia was a bit more than 50 minutes, and for bilateral a bit more than 90 minutes. The mean duration for docking was 4.2 minutes. Towards the end of the study, with a trained team, the time could be reduced to as little as 2 minutes. Shown here are the postoperative results. Of the 12 adverse events, all but 1 were first-grade complications. They are the ones you would expect in inguinal hernia repair, like minor hematoma, seroma, or persistent groin pain in the 30-day follow-up. The only serious complication was a grade 2. In this case, the patient was readmitted because of small bowel obstruction that could be managed conservatively. In conclusion, the Dexter system is a simple and accessible robotic device assisting the surgeon for the treatment of inguinal hernia. This multicentric study demonstrates that the robotic top using the Dexter robotic system is safe and effective, as the procedures were successfully completed with a very low conversion rate to laparoscopy and an excellent performance.
So I hope I could give you a good overview of how the inguinal hernia repair with the Dexter robot work. This is just basically raw data, unpublished data. I just wanted to give you an idea on the learning curve on inguinal hernia. These are my personal cases for the unilateral cases. The high outliers you see are, the first one is a scrotal hernia. So just to show you that pretty early on we felt comfortable to even tackle the more complex cases. And the other ones were retops, where we took out the mesh and put a new mesh in again. So for those of you that perform this kind of procedure know that it can be very difficult. And you might say it's a bit crazy to do those cases this early on, but it's just different with this system, because you can very easily switch to laparoscopy, and whenever you tackle a situation you don't feel comfortable with the robot, you do that, you perform this part of the procedure and you go back to robotics again. So you basically can tackle almost any procedure straight away, and whenever you feel uncomfortable you switch. And I had the possibility to share my experience and also the study data on other congresses. We just lately went to SAGES Congress to the US, and I had the possibility to talk to a lot of US surgeons, and there I realized that in the US they have a total different scenario. So one of the big issues they have to tackle is that the young career surgeon only get trained in robotics. And this showed me just how far the young generation of surgeons is falling behind, because robotics in Switzerland or in Europe is just very rare for the young surgeons to be able to do. And maybe also the smaller hospitals who do not have the funding for an expensive robotic system have the same problem as well, and we're gonna need a solution for them not to leave them behind. And so the biggest value for me as a young and early career surgeon is that this system really is a perfect teaching tool for robotics. It is affordable. You do not need a proctor present. When you're able to do laparoscopy and you always have the fallback position to laparoscopy, you basically more or less teach it to yourself. I mean, you have to do training and you have to, of course, benefit by the experience of others, but it's not the same as in other systems where you have to be able to perform the procedure robotically from day one. And what's also always discussed in robotic surgery is the learning curve. So do we lose quality and do we lose control during the learning curve? And when you have a system where you in the end of the operation very easily can change to laparoscopy and finish off the operation by maybe doing a stroke or two there and there to make the results better, you don't really lose quality in your learning curve. And I think this is very important and just fair to your patient, because patient safety is just very important. So I really think for the young generation and hospitals that didn't have access to robotics, this system really can be a game changer. And so as an outlook, as I'm now at Here's London Clinic, I'm very happy that they just joined the Dexter family. And they had a similar problem that other hospitals have. They were maxed out with robotic capacity. They were looking for a new system, but all of them are, or most of them are very costly. The robotic surgery was actually limited to certain procedure, to certain insurance classes, and of course, like every hospital, you want to optimize your business case with just an efficient system. And just on May 17th, we were able to perform the first robotic inguinal hernia repair at Clinic Here's London. Me and Professor Kuchen did this procedure. And there were over 9 surgeons involved across all departments at Here's London, at gynecology, urology, and general surgery, who are happy to start the program as well. And I'm very much looking forward for the continuity and expansion of my work there. And one of my personal outlooks that I'm looking forward very much is the 21st of June, where we have a live case where I will perform an inguinal hernia repair at Cantonal Hospital of Winterthur, and we have a live transmission to SRS Congress over Proximi. So this will be a big benchmark for me personally. And as a summary, I really think the Dexter robotic system can be a game changer. It can help the young surgeon get taught in robotic surgery. It can give access to everyone. He can give access to the young surgeon, he can get access to the general insured ambulatory patient, and I really had a great journey so far, and I'm happy to be a part of it, and I really think that Dexter is here to stay. Thank you very much for your attention.
Thank you very much for the invitation. It's a pleasure to share my perspective with you. I will touch several aspects you have just heard, but I will try to add my perspective on this. I have to declare that we have a development and research cooperation between the Kantonsspital Winterthur and Distalmotion. Since I have a chair position in a public hospital like the Kantonsspital Winterthur, I have the responsibility to create opportunities, to open doors and to educate. We have one robotic system from the current market leader in our hospital, and for 1.5 years we are gaining now experiences with the Dexter system. I have to evaluate whether Dexter is a promising option to develop our robotic program forward. Before I get to the question how to implement Dexter, the overriding question is why on earth Dexter? And why is the most frequently asked question to me also at this Congress. My answer to the why is based on my motivation and my goals. The goal is my team. So I want to create an effective and meaningful surgical department. And I defined 3 aspects which are of importance. First, an attractive spectrum, surgical spectrum with modern surgical techniques and technologies. Second, I want to have the best team. We need to be attractive, particularly for the young surgeons. This has to do with structure, with program, but also with the cultural environment. And the third point is I want to offer an attractive educational program with a transparent selection process. These goals lead to specific requirements for an additional robotic system. It needs to be technically convincing, simple, flexible, available, accessible, and last but not least, inexpensive. So quite a high hurdle for the industry to fit with these requirements. But coming back to the why, I have the impression that Dexter fulfills many of these requirements, and Dexter is definitively different from existing robotic systems in abdominal surgery, and I think Dexter is a step in the direction of how I think abdominal surgery will develop in the future, and this fits quite well with the opinion of Dieter. I think in the future it is a combination of the best aspects from different minimally invasive systems, robotic, laparoscopic, allowing a lot of flexibility. Let's focus on some aspects, beneficial aspects, which make Dexter attractive for a demanding surgical team, which is trained in laparoscopy. Thanks to the mobility of the individual elements, the robot can be used in different ORs. The manipulation of the robotic arms is simple, as we have seen already, which leads to short docking times. The use of the handles is very easy, also the pedal. Taking these aspects, all of them together, Dexter is accessible for all surgeons in our team. Compatibility, like the majority of visual surgeons in Switzerland, also in our team, we are minimally invasive surgeons, well trained in laparoscopy. Therefore, laparoscopy is our standard if we evaluate robotic surgery in terms of outcome and costs. And however, the application idea of Dexter is not to replace laparoscopy, but to supplement it. The switch between the laparoscopic and the robotic technique is part of the application model of Dexter. Dexter offers somehow the flexibility to choose the most suitable surgical technique. Surgeons decide whether procedures should be done fully or partially robotic. And speak about cost efficiency. Also in Switzerland, costs are playing the most important role about the implementation of a robotic system. Compared with other robotic systems on the market, Dexter is significantly cheaper. The problem is the comparison with our gold standard, which is the so-called conventional laparoscopy. At the end of the day, a robotic surgery is more expensive than laparoscopy. This is also the case for Dexter. The question is the delta between the costs for robotic-assisted and for laparoscopic surgery. As long as this difference is not too high, my team can apply Dexter as much as it is possible. And they do cholecystectomy, hernia surgery, and we need absolutely a high volume of smaller robotic procedures, otherwise we will never achieve a large-scale adoption with a robot. So the economic advantages of Dexter is very important in the current economic pressure, and I can only advise to Distalmotion, keep the system simple and cost-effective. Let's look at the Dexter-specific education and training. Dexter is simple, flexible, and accessible. Therefore, the training program can be short and efficient. Accessibility for all visceral surgeons, particularly the young surgeons, even without experience in robotic surgery, is important. The learning curves are short. And this is the Dexter program. It includes and starts with the fundamentals. Then we have to learn and guide the simulator. At the third point, we have hands-on aspects with dry labs. And as a last but not least, there are wet labs offered by Distalmotion. Here we see an impression from dry lab and wet labs. The dry lab was installed in our own OR in our hospital. And the wet lab is more time consuming. Every surgeon is performing one wet lab training before going to patients. I give you my perspective on the Dexter implementation. The implementation of the Dexter program in our hospital was quite cool. From the beginning, all surgeons were invited to participate to the Dexter's program. There were requirements like experience in laparoscopic surgery, so the level of the Facharzt, and participation to a training program. The first 10 operations of a starting surgeon had to be done together with a surgeon with Dexter experience. And I wanted to have somehow the zero-risk approach. So those who operated had to convert to laparoscopy in any case of uncertainty. No significant prolongation of the OR time was also a requirement. And they have to start with hernia and cholecystectomy. And we installed the quality control from the beginning. We consecutively collected the data. And Dexter implementation is somehow, to summarize, a great chance for a surgeon's team. It's safe, it's efficient, it leads to a high motivation, particularly for young surgeons. And by the high volume, we gain a lot of experience in a short time. And within the 1.5 years, we collected these 200 cases, as you see here. Inguinal hernia and cholecystectomy are the majorities. abdominal hernia. And then we approached also the more complex procedures as pancreas procedures, colonic surgery, bariatric surgery, and also diaphragmal surgeries. We are currently writing manuscript and publishing our outcome, and I don't like to communicate the results in official congresses like this one prior to the publications. I hope you understand, and we will be able to discuss the results in future meetings. Here, I give you a quick look. It's a somehow video snapshot to the first pancreatic head resection. We do here the anastomosis of the pancreatic duct with the jejunum. It's really a short video. We are currently preparing a longer one. We have a lot of video material from this case. And a second impression is here at the diaphragm. This suture has been done by Felix Grieder. It's a suture at the cruise of the diaphragm, and it's one of the first diaphragmatic hernia operation you see here. Coming to the conclusion. Dexter makes our surgical department attractive. It can be used complementary to laparoscopy and complements also our robotic program. The increase in costs by using the Dexter is quite limited, and it makes robotic surgery accessible, particularly to young surgeons. It can be integrated into a surgical training program, and we can choose the best surgical technique, either fully or partially robotic. And if we look forward to the future, there are hurdles. We need to improve the Dexter performance, and Distalmotion is working on that continuously. And we have continuously also to approach to the more complex procedures and make further experiences. And at the end of the day as well, important for the company, please keep the costs low. And with this, I end here. I thank you for your attention.
Before we answer all your burning questions, I'll give you a short outlook on training, because we have heard now, again, we are old, not all. Two of us are old surgeons, or older surgeons, and a younger one, and we have to train. And how are we going to train the future surgeons? You know that, a surgeon needs knowledge, needs judgment, and needs skills. And you all know that the traditional apprenticeship is outdated. We know that from COVID. We also know that it's not very efficient in Switzerland. We published just now a little study showing us that the training we do currently now is not efficient. So the future is competency-based training. EPAs, you all know that, have been implemented now in the core surgical curriculum of the Swiss College, will be implemented in the surgical degree in Switzerland and in many others. And so this will be modern. Modern surgical training also just not teaches technical skills and much other skills. Obviously, for the robotic platform, we have to focus on the technical skills. We need to teach our young generation, and this young generation needs gamification. It doesn't work anymore just doing on a very simply box trainer doing such exercises. You need to challenge them, you need to show them the limits, you need to create a kind of championship feeling in training. And this is what Dexter Academy is also doing in their approach. You've seen that already, the different steps of the training, going from fundamental how to use the machine, to simulator training, to hands-on dry labs, and to hands-on wet labs. My personal feeling is, and I can be challenged on that, that's not absolutely necessary. So what is being done currently is the simulator training. in conjunction with another Swiss company, Virtamed. They developed the robotic simulation training, and this is kind of teaches you everything you need to do, you know, to control the instrument, to do suturing, and that can be done in a very safe way, environment, not harming the patient, not harming anything, and in a little bit competitive way also by doing that. So this is one part, and the simulation-based surgical training is the future. We have another big project, it's called the Proficiency Project, which is actually working on that to integrate simulation in any training curriculum. And here we have the dry lab. The dry lab, I think this is very good you don't need more. This is like a rectum resection model. You see me here in the company's office, just doing that, training that very nicely on a plastic silicon-based model. Here you can do a lymphadenectomy on the iliac vessels. So it trains you the steps, it trains you to do perfect way, in a safe way, without using animal cadavers or anything else. And here you see me on the simulator training, doing the simulator exercises, and we are currently in the process of validating the curriculum also for the surgeons, because surgeons need to be integrated in the training from the start, from the beginning. We cannot just have the young residents not being trained now in robotic surgery. And that's the dry lab they have set up in Epalage. It's very nice for us. It's just 3 metro stations away from the hospital, so we can send people up there. And we're doing some little trials, and we're also trying to find the perfect way of offering to young residents a first approach to the robot very fast and very easily. You have heard a lot now on training, thank you very much, and I'm happy to now open the discussion for the panel here present and specifically answer all your questions. You must have tons of questions. Please, raise your hand so we can have the microphone circulating. Well, if not, then oh, you have one, Dr. Petermann from Morsch.
Thank you very much. The question of course, of efficacy in terms of financial aspects, operative time is a question for us as a regional hospital. We are not a canton hospital, we are not a university hospital, so the funding is probably a little bit different. And my question is, as we are old surgeon, we are quite performant in performing simple laparoscopic operation, meaning in operative time and so on. So we have a large number of patients treating laparoscopically with a huge, many patients, and also a good patient satisfaction. And so the implementation of a robot in our hospital is a challenge for these questions. The operating time will be longer, and the patient satisfaction is questionable, and probably our director, our administrator also could have a question about this. So how can you advise for these questions?
Well, I think the best answer that would be Stefan. So in another way, asking his questions, how do you measure or define success of implementing as a CMO? Now you have to put on the CMO head. How do you measure that it's implemented in a successful way? How do you as a surgeon have to convince yourself as a CMO and especially the CFO of your hospital to do that?
That's a very difficult question, and questions we are discussing more or less every day on the different levels. And I try to say that whatever we do, robotic surgery will increase costs compared with laparoscopy. We do not compare anymore with the open surgery. So those benefits are already gone. We have to compare, as you said, with laparoscopy. That's quite difficult. So you have to identify other arguments, and one argument is a strategical. So many hospitals really focus on robotics. If you look around, if you look at these 2 days we spent here, everywhere we had discussion about robots and robotic surgery. So it's coming up. Whatever we do, it will come. And I think if we realize that this technique will come on the market, will maybe in the future dominate more than it's doing now, then we have to make a step now for the future. I think this strategical aspect is maybe the most important, and for many hospitals it's at the end of the day also then a question of the investment, of the amount, of the price, the really absolute price. And it is a significant difference currently between Dexter and the other systems, and that's why there is an advantage still with the Dexter to go now. And there is a possibility that many surgeons can learn and adapt now, and it makes, I think, at the end of the day, your clinic attractive when you offer also robotic surgery. And that's what we observed, that smaller hospitals as well, they observe that the larger hospitals, they do operations more and more with a robot, and they even don't have a robot. So with the Dexter, it becomes somehow possible to approach to this technique as well. So I think it's mostly a strategical aspect. And then is a second one, maybe, surgeons' comfort. I think you mentioned that in your talk as well. Why not to consider also surgeons' comfort? We have also to keep us healthy. So that's maybe in the future more and more, and with the young generation as well, a new aspect which is coming into the field.
I think what's important, it will not come, it is here. And if we don't do now, we are going to be late. And our part of the university is to train the next generations of surgeons, so we have to invest in robotic training. And just keep in mind, the robotic platform is a laparoscopic access with a robot, so it's not also laparoscopy, and it should be used whenever you feel like it's the best to use. When I just came back from a big academic center in the States, they have 100 ORs and they have 25 robotic platforms. And they can use the robotic platform whenever they think it's needed. It's best for the patient. It's like a commodity to have a robot there and everything is done. And we are far away from that. We need to get loose of the idea, oh, the robot is done only by the old chief surgeons or the chief guys. It needs to be done by everywhere. It is here. It will not go away, the robotic platform. There might be more coming up or expand everywhere. So we need to incorporate it now. And obviously, all hospitals struggle with finances. I don't have to tell you that. We are the worst one in Switzerland. So I don't have to tell you that. So we all struggle with finances. And obviously, it's very difficult to convince your hospital to buy in such a system, but it's needed. There is no way around it.
Yeah, thank you. That's exactly what I wanted to hear. It's a strategical decision. But now our problem is that our direction has to understand that. That is a strategical
Well, we're happy to come and talk to them.
Thank you.
We have one question there from Beat Glor, and then one in the front here, and then another one back there.
Oh, Beat Glor from Bern. Well, thanks first to the panel for the excellent talks, and I fully agree with what you said about the hybrid technique, so use the advantage of the robot and the laparoscopy. We don't have Dexter, but we do robot hybrid technique. So my question is about cost and development. So, for example, the cholecystectomy, for a standard cholecystectomy, there is not much advantage using the robot as compared to the laparoscopy. So do you think this is just for the teaching and for developing, go through this procedure in order to be later on trained for the more complex, or what is your opinion about that?
Maybe Lucas, you can take that question.
Yeah, I think, as you said, you do not have a big benefit by the robot in the cholecystectomy. I actually had some cases where I had a benefit because you had the possibility to angulate where you maybe had a gallbladder very much inside of the liver. But basically, this is a learning curve procedure. And so this was the first procedure, as Professor Breitenstein was also thinking about pancreas resection or surgeries in this area. So it is a learning curve procedure, I would say.
But I think we need to, obviously the financial guys of the hospitals, they want to see benefits. But the benefits cannot be shown in a laparoscopic robotically cholecystectomy that we all agree as surgeons. But again, you know, I have a computer here. It has lots of things to do, but there's no benefit of having that. Who of you has still a simply phone that can only do phones? Everybody has this super smartphone. It's exactly with the robot. We need to incorporate them. And the next generation, we have difficulty training them in open cholecystectomy because nobody does open cholecystectomy. We train them in laparoscopic cholecystectomy. If we don't train them in robotic cholecystectomy, we are just not timely anymore. There was another question from Martina Witz.
Yeah, I'm Martina Witz from Birtamed. I have a question to Lukas and Stefan. Do you think that Winterthur becomes more attractive for residents because you have a Dexter? Because you open the way to robotic surgery quite early, like
Well, they think they are, but are they really?
Yes,
Yeah.
I'm
Challenging you here.
Yeah.
It's hard to know that because I was already at Winterthur when we started the program, but I talked to a lot of my young colleagues, and a lot of them would like to have access to robotic surgery, and they're really amazed how much access we get because of this system. So I would say it is an argument to come to Winterthur because even as a young early career surgeon, you get access to robotic surgery. So if I was younger and I was deciding where to go, this would definitely be a factor for me.
So let's ask two students. I see two students here, you know, medical students, 5th year. Would you go rather to a hospital that does not have a robot, or would you rather go to a hospital that has a robot? A very open question, obviously.
Yeah. Actually, that's a good question because, you know, as a new generation, we are really into technology, and I think also surgery has to be interesting for us with tools. So I think for the young generation, I think those tools are also really interesting for us to go into. And you know, like a tool, I wouldn't say a game, but you know, like it helps us also to be interested in surgery, I would say. What would you say, Elia?
Yeah, and maybe just a thing, we're listening, you know, and the speech is not for us medical students. But still, we're listening to it and thinking, wow, they're looking for people testing the simulators. Oh, wait, maybe we could, like, ask them, we could, like, give the medical students to test the system. And for us medical students, you know, most people, what are they doing for surgery?
You will have to come. We're
suturing.
planning that
They're
study
practicing
already.
suturing. But imagine you could incorporate this. And just yesterday we had a different talk where it's like, you know, there's so many companies, which is like the one where you start like doing the advertisement. And it's like the thing they said is like the different cars you drove in your life, you don't remember them that well, but like the first car that you drove, you will always remember. So just, you know, maybe as an idea, you know, you can also really use this for medical students because they'll be the future surgeons. And if they get to know it early, because everything you do, it sounds like make it as easy as possible to start with robotics. Because that's really something I kind of heard. It's like, I mean, of course, there are other systems, but like, what's the benefit here? One thing is like, I give a big access. So yeah, very interesting even for us.
Perfect. I hope you recorded that. That's a good statement.
For sure.
Down here, it was a question. Can you just wait for the mic, please?
It's like a similar remark than the student right here. I'm just a resident also.
Not just, you are a resident.
I am a resident. But again, there is a lot of companies, and we want to know with which company we have to commit because it is a different technique also. Is it as easy to switch between like an Apple and Samsung? Or is it complicated?
Yes, it is. I'm doing robotic surgery on 2 platforms. It's a no-brainer. You can easily switch. It's like driving a German car and then going to an Italian car. At the end, they work the same way. Not to name any names here. It's the same way. One is more fun than the other one. No names again. But the switch is very easily from one robotic platform. They all have common concept. It's not like they're completely different. They're similar. They have their little differences that you need to learn. It's like shifting a shift car or an automatic car, the little differences. So that is really there. But I have, okay, another question here.
Yes. Alexander
Could you just
from
state
Geneva.
who you are so we
Yes,
know everybody?
Alexander from Geneva.
You're also a surgeon?
I'm a staff surgeon.
Okay, perfect.
So my question, it is probably, if you said it, I missed the first presentation, but how easy it is to bring the Dexter in, for example, an unexpected situation. I understand that you are doing only elective case, of course, as the implementation protocol, but for example, if in the future, if you are in a difficult situation with an emergency case, how easy it is to start the robot, to prepare the robot and bring it to just do a part of the surgery with the robot. Because of course with Da Vinci is to bring the whole system in the...
Well, you bring the patient to the other platform, here the platform comes to you. Very easy. So that would be robotic surgery 5.0, meaning using it in emergency situations. It's done in Brussels on a regular basis, I know that. But again, with a platform that needs the patient to go there. And here, you have shown it nicely on your video, Lucas, you know, you can just drive it around and bring it into the OR where it needs to go. Obviously, there are lots of other hurdles that if I tell my nurses in emergency, I would like to have a robot, I'm gonna be dead right now. But in the future, probably not, because I think exactly that is the beauty of Dexter. You can use it where you think, now I need the precision of the robotic platform, and that is the real advantage.
Okay, thank you.
Thank you. I have a question to Michael. Michael, as an engineer from heart and now an entrepreneur, what do you think are the biggest barriers nowadays to include robotics in everyday surgical life?
I think it relates to the question that you've asked before. It's having an honest conversation. We all know that robotics has certain benefits that has been demonstrated over the last 2 decades, but I think what we needed to do is to have an honest conversation of where robotics truly brings added value, because traditional approaches have separated the surgeon from the patient with a robotic interface. They have forced the surgeon to do everything robotically. I think that paradigm doesn't make sense. We think robotics needs to become a partner to the surgeon at the table, available when needed, and to go through that more bottom-up, more honest conversation instead of being tempted by features and bells and whistles you can add to thrive for simplicity. That was not easy to do, but I think it's super critical because it not only gets the complexity down and it improves simplicity, but it also addresses what you have been talking about a lot, Stefan, is to make it then not only available and accessible to the surgeons, but also available and accessible to the healthcare systems, to the hospitals. Because everything you add on complexity is complexity you need to pay for. And finding that right balance has been one of the key challenges we've worked through, and I think today we can say we have overcome them.
Exactly, keep it simple and affordable. And Lucas, what are the most key learning points to become a Dexter robotic surgeon?
Yeah, so to answer this question, I really want to stand up for the new generation of surgeon. So my key learning point, in my experience I had in Cantonal Hospital of Winterthur is that even though everybody was open to use the system, some of them still were hesitant because it was robotics, it sounded very complicated, it was just the one complex machine up on the hill that was never reachable. And so some of the young colleagues were a bit hesitant, so I really want to advise you, if you get the chance to get into robotics and especially with this system, it basically is very easy. Not tell it to everybody, but it makes it very easy, it makes it very comfortable. So you have to put in some effort, but it's really not very hard to do if you have a lot of electronics in your life and you're used to doing electronic devices.
It's not rocket science. It's easy to use, easy to learn, and easy to apply. Another question from
Yes,
Dr.
one clinical question that is not related specifically to Dexter, but to robotic surgery. It's about the trocar morbidity. Now we can perform a cholecystectomy or appendectomy with a 3 or 5 millimeters incision. No hernia, nothing aesthetically. It was also very nice for the patient. So it's the same with other robotic platform. But what's your comments about?
Well, currently it needs a 10 millimeter trocar, but everything gets smaller with time. And they will get also smaller, but to be honest, I have never seen a patient complaining about a 3 millimeter, 5 millimeter, or 10 millimeter incision. There is trocar hernia, I agree, but it will get smaller, and Michael will tell us when.
But Dieter, you don't close the trocar. It's your assistant or your chef.
No, we never close. Never close in 8 millimeter incisions and 10 millimeter incisions or 11 millimeter. We do not close them in any case.
So today we indeed have certain Covidian trocars that are 8 millimeter that work with our instruments, and by next year we will have all 8 millimeter trocars compatible. And something that is quite interesting, given the flexibility you have on pore placement, for example, in hysterectomies, when you do it laparoscopically, you have your instrument incisions below the bikini line for the good aesthetic result. When you do them with other robotic platforms, your trocars, they move up. Thanks to Dexter and the ability to do the complex parts of the hysterectomy with Dexter, and I'm again not pretending to be a surgeon here, but the simpler parts of the procedures laparoscopically, the trocars, they can again move down below the bikini line. So there's indeed, procedural innovation you can do with these types of approaches.
And the trocar morbidity is not there except from hernia, because the pivot point is in a way set. You have to set that as in every robotic surgery. So it's in the abdominal wall, so there's no stretching, tearing of the abdominal wall, and their pain is minimal.
I think that could be also a nice field for studies in the future, like randomized controlled studies. Why not? It's a device from Switzerland. We are at the beginning. Why not to initiate randomized controlled trials already? It would not be too complicated to compare laparoscopic against robotic assisted. And for this, maybe we should also initiate then a registry for those who start with the Dexter, and we would soon have a lot of.
We need
data.
a Swiss registry on Dexter robotic surgery. I think that we both agreed, Stefan and I, already many time ago. So we need that, and whoever starts doing it, if you give us data, it's only with, I disagree a little bit with the prospect randomized trial, because those kind of trials are getting old, are getting not used anymore, but we need the real world data. And I think we need to demonstrate in a real-world setting that there is advantages, and even if it's only the sitting position of the surgeon, that's still a huge advantage from my perspective. So we have to wrap up. Time is over. There are some drinks and food here for you who want to stay, and we obviously all are here if you want to ask us questions that are just for our ears. So please approach us. I thank you very much for being here. I thank Distalmotion for supporting our Congress, the Swiss College of Surgeons annual meeting, and I hope you still stay. And just because Michael at the introduction said, welcome to a beautiful day snowing in Davos, I have to remind the guys watching, it's 1st of June. Thank you very much.